Hi, everyone. I know you guys love to accumulate back there, but fun fact I just learned. Should I share it? It's on a plane. That's okay. So personally, we had this conversation over here about how all of you like to clutter up there, and if there was ever an emergency, you wouldn't make it out alive. So fun fact that you could share is if you're on a plane, 5 seats from the exit, you're more likely to survive. There's exits here, exits there. So feel free to come down. I'm not trying to be morbid. It was a joke, so I apologize if anyone has had any adverse. But it would be nice for you to spread out. So we appreciate you being here. Please do scan in. Stay for the entire thing because each presentation is pretty phenomenal. And students have worked really hard to, you've done great jobs for those of you who are here who presented, but also the students who are here presenting have done great jobs so we can experience the whole thing. What you see in front of you is the program, the cover of the program. That QR code amongst the 50,000 other QR codes that you've seen today and in your lifetime takes you directly to the abstract book. So please do take a look at it. It gives you a sense, particularly if you're first year students, of what abstracts look like that get to sort of to this point, and just to sort of have a range of those, because you may not have been able to visit all of the poster presentations, but they were pretty phenomenal. So I am lucky because I get to, so before I get to that, so this is the program for the rest of the afternoon. I'm going to basically thank a lot of people. Dr. Thomas will come up and speak. Dr. Charney, unfortunately, contacted us yesterday saying he's not able to be here. He would normally be here. He's been here year after year after year, and he stays for the entire thing. So he does know that we do record this and we do Zoom in. So hopefully he will still be able to see and hear a lot of your wonderful presentations. He's really enjoyed it a lot. We have 4 student presenters. So how do we select these presenters? We look at, so the MSRO faculty, who many of you have had facilitated, depending what sessions you were on, Keith Siegel, Micah Van Gerwen, Jenny Lynn, and myself, review most of the abstracts that have been submitted. We look for projects that are well written, good science. We look for diversity in kinds of topics. We don't want 5 bench cancer research studies. So we're looking for a range of different topics that we think you can also connect with, and for students at different points in their training. So you'll hear from 2 students who are second-year students. You're going to hear from students who's a scholar year student, and one who is an MD PhD student who finished his PhD. So that's the program. But before I turn it over to Dr. Thomas, I do want to let you know some data or information on the presentations of today. They were in all of these different topics from A to S. I think there's 30 of them, which means you're all selecting projects in areas that either you're interested in exploring or have found a really fantastic mentor, but they really run and range quite a bit. We usually have you for urology, but this year we didn't. But yes, it covers the full range. None of this would be possible, so I get to come up here and thank a lot of people, and so I'm going to start by doing that. So you have your scholar advisors. These are the names of the scholar advisors. They have expertise in different types of scholarly activities. Some of this may be AI, might be in medical education, might be in medical humanities, clinical research, basic science research, and global health. And so these individuals are here along the way. For the students who've presented, they've gotten feedback from their scholar advisors along the way on helping develop the study and also refine the study for something that might work for a medical student research day. We don't require that you publish this work. Many of our students go on to publish this work, but it is very different to go up and present, as many of you saw those posters, and in 5 minutes, how do you condense what you've been doing for the last 15 months? It is hard. And then the oral presenters will be a few more minutes in terms of presenting what they're doing. So thank you, and thanks to the scholar advisors. These are the mentors. And so we can't name all of them, but I did list them all. So just give me a moment as they circle and make their way through. Without a lot of these folks, obviously you being able to do projects wouldn't be possible. I know we require you to have mentors, but there's valuable different exposures, ideas, contents that they provide. So I'd like to thank the mentors who have mentored both the students for poster sessions and oral presentations. I'd also like to thank all of the presenters in advance. Since this portion is the oral presentation, not everyone may have been there to sort of see your oral poster presentation, but nevertheless, I wanted to have your names displayed on the screen. So thank you very much for everyone who presented. Really did a great job. I tried to bounce in and out. I know Dr. Thomas bounced in and out. There were a lot of folks going in and out of different rooms, listening, and very, very impressed with the work that you've done. So thank you very much. Poster facilitators. So in addition, we had various poster facilitators, faculty from different areas. These are their names, from Lily Chang, Francesca Cosarini, all the way down to Dr. Van Gerwen. Again, everyone does this because they care for you. They want to give you this feedback. They want to develop and help you, give you feedback in different ways and ideas. So I hope that that was something that you appreciated as much as we've heard this in the past. Many years ago, we used to do poster sessions where students would just stand by their poster, and not everyone had anybody come by or ask a lot of questions. So by creating the structure, you do have questions. You have questions from your colleagues who are in the room, from other folks coming by. We also introduced the Zoom so that other people who couldn't physically be here could still attend. So I hope you liked that. I'm fine with getting any kind of feedback you'd like. Summer funding, many of the students who did summer research last year were funded by a range of sources. And so some of them are listed here. Some of them are internal sources and some of them are external sources. And I'd like to thank Jackie and Darenka, who also helped coordinate summer research funding, in addition to the MSRO team. MSRO team, you see up here, myself, Dr. Lin, Dr. Siegel, Dr. Van Gerwen, Grace and Yakira help do the day-to-day coordination, from your funding to publication conference funding to just helping run everything that we do. The cover was designed by Jill Gregory, and the volunteers who were here today helping to just move things along. So thank you very much. With that, I would like to introduce Dr. Thomas, or you guys know him, but he's going to say a few words to you.
Hey, everyone. Good to see you all. Glad you're here. And thank you, Dr. Rojas. And just a couple words just to start us off, and probably thank a couple people that already were thanked. But, you know, it's this is a really exciting time for us, because often people don't get to see all the amazing work that you do, right? This is a really public event to demonstrate the incredible scholarly work that you've all done, the research, the hard hours. I mean, I was upstairs, as Mary said, in and out, and saw some really amazing presentations. And so for us, it's really fun to have this as a public display of the scholarly work that you do on top of, you know, your clinical work. And so throughout the year, right, people get to see you, you know, developing your knowledge, developing your clinical skills. It's much more individual, as opposed to here, where it's a public display of really quite impressive work. And so really, really excited about that. I do want to take just a minute, you know, to thank all the, you know, the countless mentors. You mentioned them all, but really I have to call them out. People do that because they love to do it. They love to work with you, right, and be your mentor, your PI, you know, whichever it is. And so that's really terrific. And then we have obviously the track advisors over there. But I do want to call out specifically the MRSO team. You know, Dr. Rojas, right, Dr. Lin, right, Dr. Siegel, right, do amazing work with you throughout the past year. And also, really to shout out Grace Oluash, right, because it's really important what she does. And also Yakira Encarnacion Patterson, who really does incredible. I see the thumbs up there. Yes, calling you out, because it's really great work. And it's a lot of work. And, you know, they help you throughout the year. But and today, putting this all together is no small feat, and it really has gone off beautifully without a hitch, and really has been quite wonderful. And so But you're not here to listen to me. We are here to hear 4 amazing presentations by our fellow students. So with that, I will turn it over to Dr. Lin.
Great. Hi, everyone. I get to introduce the speakers. So our first speaker is Elise Salasso, speaking on scoping medical student knowledge of first aid. Some of you contributed to the data for this with her mentor, Dr. Christopher Strutter. So Elise.
Hey everyone, my name's Elise Salazzo and I'm a second year med student. And today I'm here to talk to you about the basics. It is very fair to ask. We're in med school. There is so much complicated science and complex procedures to learn. Why spend so much time talking about first aid? I've been an EMT since 2019, and my pre-hospital experience has given me 2 answers to that question. The first is that emergencies are, by their nature, unexpected. You could be the best resuscitationist in the world, but you will always be limited by the equipment that you have on hand. And if you're walking down the street, in an airport, or alone in CT, your equipment on hand might just be your hands, or it might be any of these first aid skills that they cover in a Stop the Bleed course, an American Heart Association BLS course. And these skills are incredibly time sensitive. To put things very optimistically, a patient in cardiac arrest or with a severe hemorrhage has less than 5 minutes before suffering a catastrophic permanent insult. The average ambulance response time in the United States is 7 to 14 minutes. In New York City, it's 8 minutes. Without these first aid interventions, all the advanced medicine in the world will unfortunately not make much of a difference for patients. And that's why it's so important to learn these skills. The other reason why it's really important to have a good foundation in first aid is that emergencies are scary. It is very stressful to watch someone dying in front of you. And when you're stressed, it's hard to think. Our job as future physicians is to stop and think about what is best for the patients in front of us. Having these skills in our back pockets lets us know that if God forbid and worst comes to worst, we still have all the tools in our toolkit to take care of the patients in front of us. And in a way, that is incredibly reassuring. However, in my conversations with my classmates over the past several months, I've come to realize that maybe we don't all have the same tools in our toolbox. And that's exactly what my research has been, a needs assessment to see how well do med students know first aid. So working with Dr. Struther, I came up with a list of 11 essential first aid skills. All of you got this email with the survey in your inbox, and I asked everyone to rate their comfort with these skills on a scale of 1, not at all comfortable, to 5, very comfortable. For analysis, I defined a student as comfortable with a skill if they rated it a 4 or 5 out of 5, and I used Fisher's test to determine statistical significance. I got 92 responses, which is about a 20% response rate, and roughly 1 in 4 students had some sort of prior first aid experience, be it a formal EMS certification or something like having a shellfish allergy and needing an EpiPen. And the results really reflect what I heard in my conversations with all of you. The vast majority of med students at Sinai are not comfortable with most basic first aid skills. The only skill that the majority of students are comfortable with are naloxone use or Narcan. Exactly half of students were comfortable with determining scene safety or using an EpiPen, and every other skill most students were really uncomfortable with. What might be most surprising is that this comfort really didn't improve after the clinical years of med school. Patient assessment and airway positioning did improve, but no other skill had a statistically significant difference after the clinical years of med school. So naturally, I started to wonder, is this just us? I've started sending out this survey to other med schools, and today I have the data back from one other school that I can share with you. This other school is a little bit bigger than us, but had an overall very similar response rate, slightly more clinical med students, same rate of students with a first aid background. The biggest difference at this other school is their curriculum. At Sinai, as I'm sure you guys know, we have a mandatory Narcan training during M1, and we do a BLS course right at the start of M3. At this other school, they take a BLS class within the first month of med school, and they do a BLS refresher right at the beginning of M3 with an additional advanced cardiac life support class. And this curricular intervention significantly improves students' comfort with these skills. Sinai is the light pink in this graph, and the other school is the dark pink if you can't see that. But all of the skills that are emphasized by these AHA classes are the skills that the students at the other school were more comfortable with. And this difference actually persisted, analyzing the data further, into the clinical years of med school, where students at the other school in their clinical years were significantly more comfortable with life-saving skills like chest compressions and using an AED. So we can say that curricular interventions that teach first aid have a measurable impact on how well students know these life-saving skills. They can be taught, and they are so important. First aid is not basic life support because it's basic and it's easy. If you've ever tried to hold a BVM and keep a mask seal with size small gloves, you'll know it's hard. It's basic life support because it is foundational to resuscitating any patient, and it is essential for being able to take care of the patients in front of you, no matter how they present or what field of medicine you're in. This work is still ongoing. I'm continuing to send it out to other schools, and I've started teaching first aid classes here at Sinai. Our data from our first few classes show that even a 90-minute course makes students significantly more comfortable with these really essential skills. So future directions include figuring out exactly where in our curriculum we can put this and how much of it we should add. So thank you all for your time, and I'll welcome any questions. Some references.
Any questions?
Okay, so you guys are totally comfortable now, right, with first aid? Okay. So next time she asks you, you're gonna know. No, seriously. You don't have any questions? This was surveys that you guys, actually, probably you or some of your earlier classmates did.
Also, there are a few spots in our first aid class on May 5th, next Monday. So I'll send out another email about that if anyone wants to sign up.
Hi, thank you. I was able to participate in one of the classes and it was great. So thank you for having that.
Awesome, thank you.
My question is, this is great research and you have great findings. How receptive has the administration been to adding these courses in?
Dr. Struther is incredibly supportive, and the emergency medicine department has been very kind to volunteer their time for the first aid classes so far. All of the attendings and residents who come and help teach these first aid classes are 100% volunteering their time. They do not get any clinical buyback from it. And Michael Redliner in the EMS division has told me multiple times that however he or the paramedics that Sinai has can support us and teaching first aid, he is so willing and able to do that. I've learned that curricular design and adding things into a curriculum are incredibly complex things, and it is not easy to just plop things straight into a curriculum. But if finding a way to build some more sustainability to this project beyond just me organizing first aid classes And getting this more formally integrated into Sinai's curriculum would be, in my mind, the greatest success of this project, and I would be really excited to work on that. Yeah, Lee. Can I say that? No. Haley asked, is the other med school in New York? And the answer is no. It is another allopathic school in an urban setting. Thank you all so much.
Thanks, Haley. Our next speaker is, thanks, Elise. Our next speaker is Haley Yatman, who is coming to speak about her work with Dr. Lily Chan as her mentor, health-related social risk factors associated with the lower self-reported quality of life in patients on hemodialysis.
Hi, everyone. My name is Haley. I'm a second-year medical student, and I'm here to talk about health-related social risk and quality of life in patients treated with hemodialysis. I worked with Dr. Lily Chan, who's here, and Prashkala, who's also here. Thank you guys for coming. So what is hemodialysis? As a lot of people here know, especially those of us taking renal right now, hemodialysis is a treatment for end-stage kidney disease. End-stage kidney disease is when your kidneys stop filtering your blood and producing urine the way they're supposed to. The cure for end-stage kidney disease is transplant, but in the interim, people still need to be dialyzed by a machine that can filter their blood for them. There's a couple options for this. One of them is in-center hemodialysis. Some of them is home hemodialysis and other home methods. But the most common one for people in the United States is in-center hemodialysis. For in-center hemodialysis, people come into the clinic every other day, so about 3 days a week, and they're dialyzed for about 3 to 5 hours. This is a huge lifestyle change for people that have kidney disease, and it's a big burden for patients. Actually, this treatment wasn't meant to be a long-term treatment. It was just meant as a bridge to transplant. But with the organ shortage today, people end up being on dialysis for years, sometimes to the end of their life. Many of us may know the term social determinant of health. I hope everybody does in this room. A social determinant of health is a condition that affects a group of people or a neighborhood or a society on the whole that affects their health outcomes. An example of that would be if a neighborhood has polluted water, for example, or if there isn't a hospital in a particular area and they don't have access to the hospital anymore, that can affect people's health outcomes. A social risk factor is a non-medical individual level factor that affects one person's health. So for example, if someone lives in a house that has lead paint, that might affect their health outcomes. Or if they live in a safe neighborhood, but their home is like they're subject to violence at home, that can affect their health outcomes on an individual level. We think that health-related social risk factors affect people's quality of life in patients treated with hemodialysis. Obviously, none of these factors exist in a vacuum. People's identity, their social context, their employment status, and other things affect both their health outcomes, their quality of life, and also their health-related social risk. So why do we care so much about health-related social risk? I'm glad you asked. Health-related social risk is a risk factor for end-stage kidney disease, so it's super prevalent in this population. Also, health-related social risk is estimated to account for almost 80% of all health outcomes, which is obviously a huge number and requires intervention. Some health-related social risks have also been shown to be associated with poor outcomes for the general population and for people on hemodialysis. This includes increased emergency room visits, increased hospitalizations, increased mortality, just to name a few. But what we're really interested in is quality of life. What I mean when I say quality of life is the impact that a person's kidney disease has on their general well-being. We are interested in whether the health-related social risk worsens this impact. It may seem obvious that health-related social risk factors like food insecurity might directly impact somebody's general well-being, but what is not obvious is that it would worsen the impact of disease on their well-being, and that's what we're interested in. Quality of life is a priority for patients with any chronic disease, particularly those that might be on treatment until the end of their lives. And it is also associated with other health outcomes, again, like hospitalization and mortality in the general population and patients treated with hemodialysis. To assess quality of life, we use the specific kidney disease quality of life questionnaire, which is divided into 5 subscores, each of which are analyzed individually. The quality of life subscore is scaled to be from 0 to 100. 0 is bad or worse, and 100 is the best, so the best quality of life. We assessed health-related social risk using the Center for Medicare and Medicaid Services questionnaire, and each social risk factor was either yes, they endorsed having the social risk factor, or no, they did not. 721 participants were screened, and after applying the inclusion criteria, 324 participants were included, all from dialysis centers that are in New York City. These patients were interviewed at their dialysis unit. So our first question is there a relationship between health-related social risk and quality of life? And what is that relationship like? For that, we did a univariate linear regression. The second question is whether or not that relationship still exists once accounting for other patient factors like income, employment, age, gender, race, ethnicity, etc. And for that, we did a multivariate linear regression adjusting for these other variables. 39% of our patients identified as Hispanic, 49% identified as Black, and 12% identified as white, Asian, or other. 58% of our patient population identified as male, and our mean age was 59 years with a standard deviation of 14 years. This is our overall distribution of health-related social risk factors. As you can see, more than half of our patients endorsed having at least one unmet social risk factor, which when you think about your own life is a pretty big deal. That means over half of our patients either had housing instability, food insecurity, transportation insecurity, or something else that falls under these 5 categories. Only 1% of our patients endorsed living in an unsafe environment, so we excluded that from the further analysis. As you can see, our quality of life subscores varied, with the lowest being physical component score on the far left, which is how kidney disease affects your physical health, and symptom score, middle on the right, which an average of 79.9. When you compare to other people that are enrolled in Medicare that are generally healthy, there's a lot of other quality of life subscores that you can use, but once you transition that to be on the same scale as a KD-QOL, on average, people tend to have a score about 10 points higher. So this is lower than average for people enrolled in Medicare. This is our univariate linear regression. Everything highlighted in yellow is significant, and there's a lot going on. So just to clarify some things, you can see that people that endorse housing instability, food insecurity, transportation needs, or having at least one unmet social risk factor are associated with having a lower quality of life score. That means that these things affect people's kidney disease-related quality of life. And the biggest impact is on the burden score, meaning that having an unmet social risk factor affects the burden of kidney disease on someone's life. For our multivariate linear regression, we adjusted for all of these factors on the bottom. And as you can see, some of the things are no longer significant, likely because their effect is mitigated by the inclusion of some of these factors. But still, housing instability, transportation needs, and having at least one unmet social risk factor is associated with a lower quality of life subscore, which is important when you think what we're controlling for. Also, burden score again had the largest effect size, suggesting that having housing instability or having transportation needs was significantly associated with a lower burden score for patients with hemodialysis. And that effect was bigger than the other subscores. So we can conclude that each of our health-related social risk scores were significantly associated with lower quality of life in at least one of the quality of life subscores, with burden of kidney disease having the largest effect size. When controlling for these other patient features, including income and education level, housing instability and transportation needs were significantly associated with lower quality of life in 4 of the 5 subscores, which makes us think that health-related social risk has an independent effect on quality of life, which is pretty important. When you think about health equity, we have to think of these results in context. Thankfully, housing and transportation are physical things that someone could provide a patient. And thankfully, the Center for Medicare and Medicaid has made health-related social risk screening mandatory for all patients by 2027. That means you guys, when you're residents and attendings, will be screening your own patients for this. But it only really matters if you actually do something about it. Now that we know a lot more about our patients' social context and what might affect their health outcomes, it's up to you to actually intervene. Make sure to connect your patients with social work because they're specifically trained to help provide these resources to patients. Sometimes the city or nonprofits have resources that help mitigate some of these issues, like housing vouchers, like free transportation or transportation provided by Medicare, but patients might not know they're eligible, and they also might not, they might get ousted from being eligible. And sometimes they might need a medical necessity form to confirm their eligibility. All of these are things that you can address with your patients by having the conversation with them, connecting them with social work, and potentially using your positionality as a physician to actually provide the service for them. Even if you don't work at HRA, you can still be the person that does that for them. I want to thank Dr. Chan, who's here, who is my mentor and guided me, along with Hui and Yang and the Ames Lab. I'm so grateful to have learned so much and worked on this project. Thanks also to the Ames Lab and the RRI for all of their research help. And thank you guys for listening.
Any questions?
Yes, we got one over here. I think it's, if it doesn't turn.
Okay. Yeah. Okay. Hey, Haley. Good job.
Hi.
That was so good. My question was for the exclusion criteria, because it looked like some of them could be considered like social determinants of health. Like, why did you choose those? Like, specifically like the race one. I feel like that is something that we often look at to analyze like discrepancies in healthcare. And I was just wondering why you wanted to like control for that.
Oh, sorry, for the analysis or for this inclusion? This slide or
No,
the later one?
Later, yeah.
Totally. So that's a good question. So for the adjusting for, what we were curious to see is exactly your question, whether like race or age or income or education was underlying these effects. So by including it in the multivariate analysis, it kind of separates out each of the effects and sees which one like persists. So what this is saying is even when you add in race, it probably does have an effect, not one that I presented because it wasn't like the hypothesis. But I'm like looking at Dr. Chen. But this effect still is important. So this is kind of saying this housing instability is important even if you account for income and race.
Okay.
If that makes sense.
Yeah. Cool. Thanks.
Any other questions on either side? You guys are so quiet.
Hey, Haley, fantastic presentation.
Thank you.
So this was a question about the transportation needs, right? Was this data from the city? Because my question pretty much is about how would we be able to justify it in a city like New York, which is one well-connected, does not most of the people living within the city pretty much use public transportation. So then when transportation needs came up as a significant sort of factor in here, how did you find that surprising, or was there like a clear justification?
Yeah, it's a good question. All the dialysis centers were in like the greater New York area. So you're right, there's public transportation in New York. However, end-stage kidney disease and being on dialysis can sometimes lead to a lot of physical limitations. Also, having comorbidities can lead to physical limitations, ones that you maybe like might not even think of. So being super volume overloaded when you aren't dialyzed, for example, can make it difficult. Like when I walk on the subway, sometimes I'm like exhausted walking like even 5 blocks, and I don't even have a chronic illness that makes it difficult to walk 1 block. So it doesn't surprise me because I think when people like have to face another barrier, which is like walking very far to the train, switching to multiple trains. The trains don't always run. You have to be on time to your dialysis appointment. There's all sorts of things that I don't really consider as someone who doesn't have this chronic illness, but end up coming up when you're trying to use things that are kind of more available for people that don't have chronic illness or aren't like disabled in some way.
Hi, how are you? I'm actually a class of 98. Great work, everyone. I just want to piggyback on the transportation. I'm actually working in private practice in family medicine. So it's very easy. You just go online, and end-stage renal disease actually qualifies them to get automatic door-to-door transportation. So it's quick, very quick and easy. You go online, sign in, plug in their demographics, literally 1 minute and it gets approved. And then just go online or call, and then they can door-to-door service. So it's very quite easy. And I'm sure everything's going to be, by the time you guys come out, it'll be the same way. So there's no really quick barrier. It's very, very easy to have them go on. So no worries about that. Yeah.
Yeah, and we got another question right here.
Hey Haley,
Hi.
this is amazing. Thank you so much. Just out of curiosity, it seems like you used a kidney adjusted quality of life assessment, and I was just wondering what makes that. Is it just like a regular quality of life assessment that is related to kidney disease, or what is the adjustment that they used?
That's a good question. Sorry, I have a slide with the questions. Don't look at that. Okay, so this is some of the questions from the questionnaires. It's not really like, how's your life? And then like, I don't know, it's a little bit more specific. So there's a lot of things that come into having kidney disease. Some of these are an example, like on the right, you see like a bunch of symptoms that people have that are associated with kidney disease. And on these sides as well, it's like one of the questions is literally, does my kidney disease interfere with my life? And like, how do these things affect your day-to-day life? So it's not really like, how fulfilled are you? It's like, how does your kidney disease affect your day-to-day? Like, how much do you think about it? How much does it like affect the way that you interact with the world? So it's pretty much only focused on kidney disease, if that makes sense.
Hi, sorry. So can you go to your patient population or your study sample? I was struck by the demographic profile, particularly the racial and ethnic one, and the burden. Is this representative of patients with kidney disease? And would you think that if you looked at this in a different population, maybe in the Midwest or somewhere else where maybe the demographics were different, what impact do you think that would things change?
That's a good question. To address the first question, I think I'm addressing the first question. I think that the breakdown would likely be different in another setting. I mean, a lot of these dialysis, like one of them is like in East Harlem. So, I mean, we kind of know where we live, like the demographics of where we are. So it's likely that race would have to do with it, would change in a different population. Interestingly, we did do a bunch of other analyses that I wasn't able to include. And surprisingly, like Black race ended up being associated with a higher quality of life in our population, which I think has to do with our patient sample. And I'm definitely happy to talk offline about that later, just because it is really interesting and probably has to do with the way that we did the analysis and also like who's in our sample. But I think it just really reiterates that like this tangible need is something that kind of overrides a lot of these other patient factors that a lot of us might assume we could use as a proxy or like use to interpret all of these other things that are actually tangible things that we can actually intervene on. So I think it's a good thing to keep in mind when we see patients and see them in need that we could actually do something about it.
Yeah, that's great, because I think there's so much of a burden. We think of what I really also appreciate about your presentation is what you can do beyond that, right? In terms of the environment, the quality of life, what you can do to help someone, because the burden that they're living with their disease coming in for constant care can also translate to elderly patients, many different diseases. So I really appreciate that highlight. Thank you. Any other questions? Yeah, one more.
Hi, Haley, you did great. I remember you from my Nexus course. My question was just about race and ethnicity. It seems a little simplified because someone could be Black and Hispanic. So I was just wondering how you measured that.
Sure. Yeah, everybody was asked about like if they identify as Hispanic or not, and then also race or not. I think there are actually 8 race selections, but surprisingly, there weren't that many other ones besides the ones listed and the ones that I named. There were 4 patients that identified as Black and Hispanic, and there were 0 patients that identified as white and Hispanic. So for the sake of the presentation, I did simplify it, you're right. But in the analysis, it didn't really make a big difference on the statistical significance when we actually ran it.
Did you like count them twice or like?
I did not count them twice. I counted them as Black.
Got you.
How about now? Better. Okay. I have a question now that we're in renal. We know all these like different ways in which you can get kidney failure from various renal-based disease pathologies or just kind of total body disease pathologies. I was wondering, now that looks like you did this analysis, if there are specific kidney diseases that like have greater or lesser impacts on quality of life, now that you've established that kidney disease as a whole does in fact impact quality of life.
That's a good question. I did not do that analysis because the entire patient sample is end-stage kidney disease. So people can get kidney disease, like you mentioned, in a bunch of different modalities. There's a bunch of different things that you can have that lead you to developing end-stage kidney disease. I actually don't know if there's different types of end-stage kidney disease. I'd have to look into that. And in terms of that data, I don't think we have that. I don't think that exists, but I'm not sure. And it would be interesting to study like chronic kidney disease versus end stage, because chronic kidney disease is earlier before you start dialysis. Some people have done some quality of life studies about chronic kidney disease. I didn't do that because that wasn't the patient sample. It was just one disease in the sample. It was a good question though.
Thanks.
Thanks, Haley. So our next speaker is Nina Rodriguez, who's going to be coming up to talk about work that she did with her mentor, Tatiana Kushner, specifically speaking about evaluating the clinical utility of the 2013 EASL guidelines for intrahepatic cholestasis of pregnancy. So here we go.
Thanks, Dr. Lynn. Hi, everyone. Good afternoon. My name is Nina Rodriguez, and I'm currently in my scholarly year. And today I'll be presenting on our project evaluating the clinical utility of the 2023 EASL guidelines, which stands for European Association for the Study of the Liver, in intrahepatic cholestasis of pregnancy, risk stratification and outcomes in over 4,000 US patients. My mentor was Dr. Kushner, and she's here today, so thank you for coming. So to give a little bit of background, because I know medical students sometimes don't know what intrahepatic cholestasis of pregnancy is, it's the most common liver disease unique to pregnancy, and it typically presents with pruritus of the palms and soles and resolves after delivery. You might be more familiar with something like HELLP syndrome, which is also a liver disease unique to pregnancy. Unlike HELLP syndrome, ICP, or intrahepatic cholestasis of pregnancy, is typically not life-threatening for the patient, but it can be really threatening for the fetus, and it's associated with adverse outcomes such as spontaneous preterm birth, and even in severe cases, stillbirth. Despite its risks, our understanding of how to stratify patients by severity remains limited. For example, the significance of liver tests is still unclear, and historically, bile acids have been the only guide to management. Until recently, providers lacked a framework to individualize ICP care. But in September of 2023, EASL published an algorithm for the initial management of suspected ICP. And what these guidelines did is break it up into 3 groups. And so you have Group A, which is defined as patients that have normal bile acids and normal liver tests, B, where patients had normal bile acids but elevated liver tests, and C, which is defined by patients with elevated bile acids, regardless of their liver tests. And it's worth mentioning here that the cutoff for elevated bile acids used in these guidelines is 19. In the US, a lower threshold of 10 is more commonly used to define ICP. This is the first attempt to formalize ICP subtypes and tailor management accordingly. And so the aim of my project was to assess the distribution, characteristics, and outcomes of each EASL-defined ICP group in a very large, racially and ethnically diverse US cohort. So we partnered with the Mount Sinai Data Warehouse to collect EMR data and performed additional chart review for our cohort of suspected ICP patients. Suspected ICP cases were identified by pairing pregnancy episode with a bile acid test order. Providers usually only order this test during pregnancy if they are suspecting ICP in the patient. And we also limited our analysis to the first pregnancy per patient. So we structured our analysis around 4 key questions. 1, what distinguishes patients with suspected ICP from the general pregnant population? 2, how do the EASL groups differ in their demographics and clinical history? 3, do the EASL-defined groups predict pregnancy outcomes? And 4, are there long-term liver risks after pregnancy associated with these ICP groups? And so my results will kind of follow these 4. So of over 120,000 pregnancies, 3.6% met criteria for suspected ICP. And this is higher than the 1% prevalence of ICP that's most often reported in the literature, although the prevalence does vary by geography and population studied. Once we looked at the actual bile acid levels, we found that our rates were more in line with previous studies, with 22% of our cohort having bile acids above 10, which is equivalent to around 1%. So when comparing patients with suspected ICP to the general pregnant population, we found that they were different. They were more likely to be older, identify as Hispanic, have government insurance, and more likely to have pre-existing comorbidities. We also took a look at some obstetric characteristics and found that patients with suspected ICP were more likely to have gestational diabetes, gestational hypertension, preeclampsia, but there were no significant differences in fetal death between these 2 groups. So as a reminder, going back to our cohort of suspected ICP patients, where we had over 4,000 singleton pregnancies, Group A accounts for 65% of our cohort. Around a quarter were in Group B, and 11% are in Group C. So this is the start of the results to our second question, comparing ICP groups to one another. And while I won't go into too much detail here, what's important that we wanted to highlight is that we see over 1/3 of patients in Group C identify as Hispanic. Now, looking at the pre-existing conditions of these patients, we found that Group B were most likely to have a history of MASLD, and Group C patients were most likely to have a history of Hep C, or an immune-mediated liver disease, which is a composite variable that includes autoimmune hepatitis, primary biliary cholangitis, and primary sclerosing cholangitis. We also briefly wanted to show that Group B had the highest rates of gestational hypertension and gestational diabetes. So we then did a multivariate, multinomial regression model to confirm these univariate associations that you saw in the previous 2 slides. And the variables listed on the left are those that were significant even after adjusting for potential confounders. But we wanted to specifically highlight a few. So as you can see, certain factors like a history of Hep C and the immune-mediated liver disease are strong predictors of Group C status, whereas a history of MASLD appears to be a strong predictor of Group B status. Next, we took a look at ICP characteristics, and everything we see here is expected, but we did want to specifically highlight that bile acids above 10 was quite common in Group B and even somewhat present in Group A. Looking at outcomes by group, C had the highest rates of adverse fetal outcomes, including spontaneous preterm birth and meconium stain fluid. This figure now shows the adjusted odds ratios for spontaneous preterm birth. The variables in bold on the left are the ones that were significant on multivariate analysis. We see here that Group C had 2 times the odds of spontaneous preterm birth compared to both Groups A and B, after adjusting for all these other factors. Next, we broke bile acids up into finer categories, and we see somewhat of a stepwise increase in spontaneous preterm birth rates, particularly in patients with severely elevated bile acids, who actually had a 7 times higher odds of spontaneous preterm birth compared to those with bile acids less than 10, and this is consistent with what has previously been reported. We also took a look at the incidence of other adverse fetal outcomes. On the left panel, we see that Group C shows the highest incidence of meconium stain fluid compared to both Groups A and B. And in the right panel, we see that Group C had much higher rates of fetal respiratory distress syndrome compared to A, and B had a higher incidence compared to A. The magnitude of these differences reinforces the high-risk nature of these Group C pregnancies. For our last analysis, we wanted to show that both Groups B and C had higher rates of liver diagnoses postpartum. We then did a multivariate analysis where the outcome was a composite variable of post-pregnancy liver disease, and found that Groups B and C had over 2 times higher odds of receiving a new liver diagnosis postpartum compared to Group A. This is while adjusting for pre-existing liver disease. So to summarize, the 2023 EASL guidelines provide a practical framework to personalize ICP care. Group B deserves attention, given that elevated liver enzymes alone is not benign in suspected ICP. Elevated liver tests could serve as an important tool globally, given that bile acid testing can often be delayed or unavailable in certain settings. And the very significant association of ICP with Hispanic ethnicity is really important, and suggests we should be doing more studies in this population. We should also be considering long-term follow-up in patients with suspected ICP. So I wanted to highlight a few other areas that we're looking into. We plan to characterize patients with elevated bile acids above 100. We also plan to examine subsequent pregnancies within our cohort to track whether group classification changes between pregnancies. And lastly, incorporate genetic data into these clinical phenotypes. Thank you so much to everyone. I'm incredibly grateful for everyone's support. Sorry, my throat hurts. Thank you so much to everyone. Truly, my mentor is amazing. Everyone that I worked with on this, and huge shout out to the Portal program, who I would not have been able to do this project without. Any questions? I know it was a lot.
Hey there. I thought the talk was really, really cool. I was wondering exactly how you defined like spontaneous preterm birth. I know like that's something that like we're not always like recording exactly as that in charts and stuff.
Yeah, that's a great question. My throat again. Sorry. So Mount Sinai Data Warehouse gave us the gestational age of all of the patients, and so we were able to determine whether the pregnancy was preterm or not. To determine whether the pregnancy was a spontaneous preterm birth or iatrogenic, we actually went back into the charts of over 500 patients to look at the notes and determine that. I did talk too much.
Bring it, it's okay.
Speed of light. Thank you. That was a really nice talk. I just had 2 basic questions about ICP in general. One is, because I also noticed that what you said, you were saying that groups A, B, and C were essentially stratified based on the etiology of their elevated, liver enzymes or the bile acids. Like, some people had MAFLD or other, right? So if a pregnant woman or a pregnant patient has a prior history that would elevate those parameters, do physicians automatically suspect ICP if something like that progressively gets worse? And then the second question is, for those patients who had all of these prior existing conditions before their pregnancy, was there any influence of what kind of treatment they were on prior to their pregnancy that influences their categorization into either groups A, B, or C?
Yeah, I'm going to answer your second question first because I think it's really interesting and not something that I've thought about. Unfortunately, we don't have that kind of data, but we are collecting that for the patients with severely elevated bile acids. So the reason that group is really interesting is because patients that have bile acids over 100 are the ones truly at risk for stillbirth. And so we're going back into the charts of those almost 100 patients, and we are collecting, more specific information on what therapies they got, what was tried, what does their history look like. But unfortunately, we don't have that for the 4,000 other patients. I do think it's a great question. And to answer your first question, sorry, I don't actually remember it now.
Sorry, I was just saying, when you've got all of these patients with pre-existing liver-related, right, diseases, does that ring alarm bells for physicians later on who say, oh, well, we should keep an eye on their liver enzymes, so on and so forth, because they've got this pre-existing condition?
Yeah, I think that's a great question. And, in the audience, we have a specialist of liver disease and pregnancy. So I'm curious what she thinks about this.
Bring it over. Oh, specialist.
Yeah, no, it's a really good question because I think that ICP is a very heterogeneous condition and we still don't fully understand it. And I think that a significant portion of these people do have underlying liver disease, whether we know it or not. However, from what we do know, the bile acid level is what's associated with adverse pregnancy outcomes, irregardless of the etiology. So from that standpoint, I'm not sure that it would make a big difference from what we know in terms of like fetal outcomes, what the etiology was that led to the high bile acids. But the question that I think I want to ask Nina that may come up is, you define your cohort of suspected ICP based on bile acids ordered. How do you account for maybe some people ordering bile acids, for example, as part of like a liver diseases workup, which I sometimes do, when they're not really suspecting ICP?
Yeah, no, I think that's a great question, and I'm sure we will get it. We're presenting this next week at a conference, and so that's what Dr. Krishna was referencing. And I do think it's a limitation of the data. I will say, based on the charts that I've been in, which I haven't just chart reviewed the 500 preterm, I've done a lot of, random chart review for patients. And from what I've seen, it's pretty consistent that bile acids are ordered because they're suspecting. For those cases where they're not, and I'm sure there are a couple in the 4,000, if anything, it just, I think, reinforces our data more because it would be kind of biasing toward the null, right? You would have a group of patients that are less likely to have any sort of impact in terms of ICP. So meaning like more normal patients in our group.
Good answer. I like it.
Thanks.
Okay, are there any other questions? Okay, well, thank you for your
Thanks,
questions.
everybody.
Thanks, Nina. And so for our last speaker, we have Matthew Park, who is going to be presenting on work that he's done with Miriam Murad during his PhD years as well. So hematopoietic aging promotes cancer by fueling IL-1 alpha-driven emergency myelopoiesis.
All right. Hi, everyone. Thank you, Dr. Lin. For those of you who haven't met me, my name is Matthew. And as Dr. Lin mentioned, I'm one of the 6th-year MD PhD students. I've returned to 2nd year just this past fall. And so I'm very excited to be sharing some of the work that I did during my PhD with Dr. Miriam Murad. And as you'll probably be able to deduce from my title here, my talk will focus on our immune response to cancer. But the ultimate goal of the talk, which I hope to impress upon you, is to offer some insight into how we're advancing immunotherapy options for not just the treatment of lung cancer, but also its prevention. So an important concept to recognize as we're thinking about the immune response to cancer is the fact that there's multiple compartments. You've got the local tumor microenvironment. I'm going to see if I can use my cursor here. Yeah. The local tumor microenvironment here, you've got the draining lymph nodes where a lot of this interaction between T cells and antigen presenting cells, you've got the dendritic cells and myeloid cells, takes place most often. And then during the later stages of disease, you've got the sites of metastasis here. But with this consideration of the immune response, a lot of us only think about the T cells and NK cells because these are the prototypical immune cells that are responsible for eliminating cancer cells. But with the advent of immunotherapy, one of the things that we've realized is that only targeting T cells and NK cells with something like immune checkpoint blockade, which I'm sure many of you are familiar with, where you block these inhibitory receptors called PD-1 or CTLA-4, it only elicits responses in about 30% of patients. So the question is, how do we enable immunotherapy options for the 70 other percent of patients who don't respond to this new standard of care? And to address this, a lot of our focus has revolved around myeloid cells. So these are, again, the dendritic cells and macrophages that populate the tumors, and trying to understand how we can leverage them further and improve their ability to educate T cells and NK cells so that we can enhance the overall immune response. And in considering the myeloid cells, the two compartments that are most relevant is the local tumor microenvironment and also the bone marrow, because the bone marrow is the home of hematopoiesis, right? All of these myeloid cells and lymphoid cells originate from hematopoiesis in the bone marrow. And so among the myeloid cells that we've been looking at, my particular focus has been about macrophages. And what you can appreciate from the staining of macrophages in both healthy normal lung tissue on the left and in lung cancer tissue on the right is that you've got this massive infiltration of macrophages of these tumors. So given the fact that they have this primary function as serial eaters, that's what immunologists like to call them, they are so good at eating cell debris, and the fact that they are so abundant in these tumors, we wanted to know what they're exactly doing. And some of the recent work that we've focused on in the lab has aimed at defining what their primary function is. And interestingly enough, despite the fact that they are so good at eating away at dead cancer cells and eliminating them and hopefully suppressing inflammation, we found that these macrophages, which are abbreviated as MOMAC here, MOM, monocyte-derived macrophages, we found that they actually suppress NK cells, which are these lymphoid cells that are directly responsible for eliminating tumor cells. And it's interesting because of the fact that NK cells don't rely on education by dendritic cells. They don't need to see antigen in order to release all of these cytolytic enzymes that kill tumor cells. So the fact that these macrophages suppress the recruitment and cytotoxic activity of NK cells was quite astounding. It's never been described before. Now, to understand how these immunosuppressive macrophages are born, we then turn to our focus to the bone marrow to see what kind of signaling activities are driving their genesis. And what we found most recently is that you've got basophils, right? These are primarily responsible for allergic reactions. We found that they actually produce a cytokine called IL-4 in the bone marrow. And if anything, the cell types that are responding to this IL-4 are the myeloid progenitors that give rise to future myeloid cells like macrophages. And this interaction is what fuels this process that we call emergency myelopoiesis, essentially the generation of myeloid cells during inflammatory states like cancer. And we found that by blocking IL-4 signaling using a monoclonal antibody, you can actually eliminate or deter the progression of cancer. And based on these findings, Mount Sinai has several clinical trials led by Dr. Tom Marin studying the use of dupilumab, which is a monoclonal antibody that blocks the IL-4 receptor. You guys have probably seen a commercial or two about Dupixent, right? That's the same thing. To enhance the response to immune checkpoint blockade in patients with advanced or metastatic lung cancer. And we're also testing this in patients with early stage resectable non-small cell lung cancer in the perioperative setting. And these trials are particularly exciting given the fact that, again, dupilumab is essentially an allergy drug that we give to patients with atopy. And the fact that we can repurpose an FDA-approved medication for the treatment of lung cancer is quite remarkable. And what's even more rewarding is that you actually have several patients, for example, this patient here, where this bright density is the tumor, but you can see that it's melting away quite nicely just with dupilumab and immune checkpoint blockade. Now, one of the most recent questions that I have been personally interested in is understanding the long-standing epidemiological question of why cancer is a disease of aging. We find that mutations accumulate as you get older. We also find that the likely diagnosis of cancer across all different kinds of cancer increases with age, and we eventually realized that this is a myeloid problem, which is why I wanted to talk about this today. Now, the first unfilled gap in knowledge about this subject is we have no idea whether the association between aging and cancer is a problem of the age of the tumor, whether it's aging of our tissue cells like the epithelial, endothelial, or fibroblasts, or whether it's a problem with the aging of the immune system. So that fundamental question remains unanswered. And so that was one of the first goals of our work. And so our study provided the first modern experimental proof that it's really the aging of the immune system that is responsible for determining the age-dependent progression of lung cancer. And it's independent of the aging of the tissue surrounding the tumor. It's independent of the age of the tumor itself. And that experimental proof came from a series of bone marrow transplant experiments that I'm showing you here, where essentially we took bone marrow from either young or old mice, and we transplanted them into young or old recipients. So here, for example, in this first group, you've got young mice that have young bone marrow, young mice that have old donor bone marrow, and old mice that have young donor bone marrow. And one of the striking results that we immediately could appreciate was that basically any mouse with an old immune system has the worst prognosis. And that's based on the amount of dark purple that you see here. All of this is tumor in a cross-section of the lung. And so based on the fact that you see comparable tumor burden in mice that, regardless of the age of the host, has a young immune system, the fact that they have a superior ability to control tumor burden suggested that it really is an immune aging problem that connects the association between cancer and aging. And in fact, if you rejuvenate old mice with a young immune system, you can in fact actually rescue their ability to control lung tumors. And what struck us about this phenotype was that it corresponded to a reduction in the infiltration of these immunosuppressive myeloid cells. Again, the macrophages. Neutrophils are also known to be quite immunosuppressive. And these myeloid progenitors that we actually found outside of the bone marrow accumulating locally within tumors. Now, the complete story that we published last year includes a few more mechanistic details, such as the fact that these myeloid progenitors that I was just discussing with you produce a cytokine called IL-1. And IL-1 we found goes back to the bone marrow and tells the hematopoietic stem cells, we actually want more myeloid cells. And so it essentially generates this really pathogenic positive feedback loop where you've got, constant churning of immunosuppressive macrophages that then dampen the NK cell and T cell immune response. And, one of the tangential details is that this increased production of IL-1 by these myeloid progenitors seems to be dependent on the downregulation of an enzyme called DNA methyltransferase 3A. But the salient point, the one detail that I would like to emphasize further, is the fact that when we block IL-1, we can actually deter the progression of lung cancer. And so here, again, the dark purple here is the tumor that's populating the cross-section of the lung. If you block either one of the two variants of IL-1, you can, sort of affect tumor progression. But if you block both with either monoclonal antibodies or a drug called anakinra, which we give to rheumatoid arthritis patients, you can really affect the progression of lung cancer. Now, the nuance to this phenotype, though, was the fact that you have to do this during the early stages of tumor development. If you try to give anakinra when the tumors are already well established as solid tumor malignancies, you have no impact. And so we realize that there's a therapeutic window of opportunity for how we can disrupt the development of lung cancer by giving an IL-1 based interception. And the reason I wanted to mention this particular point is because there was a very important retrospective study called CANTOS, led by folks in Boston. And what they described was that if you give canakinumab, which is a monoclonal antibody that blocks one of the variants, namely here IL-1 beta, and you give this to patients with cardiovascular disease, none of them have cancer. If you give it to these patients, you actually reduce the incidence of lung cancer diagnosis compared to placebo controls. And so this suggested to us that perhaps IL-1 beta or elevated levels of IL-1 increases your risk for developing lung cancer. But the problem here was that when they then pursued phase 3 trials afterwards, all of the data was negative. And so, Novartis had a bad year, but the point being, there seems to be a disconnect between our understanding of targeting IL-1 as a therapeutic intervention and targeting IL-1 as a preventative measure. And that's what I wanted to kind of summarize on this slide, where we wanted to consider two particular things. Point one, that studies thus far have only examined IL-1 in the setting of treating patients with advanced or metastatic disease. And two, that canakinumab only blocks IL-1 beta, not the sister counterpart, IL-1 alpha. And so the operating hypothesis that we generated from this and that we included in our study was that an inclusive IL-1 based intervention may be most effective for high-risk patients with precancerous nodules that you typically would find in patients with a severe smoking history, patients with COPD, so on and so forth. And what was quite fortunate was that we had collaborators at MD Anderson who essentially came to the same conclusion as we did. They had used their own preclinical model of lung cancer and showed that early blockade of IL-1 is effective at reducing the burden of lung cancer in mice. And if anything, postponing IL-1 beta therapy to treat mice that already had a very solid tumor malignancy had no particular effect. And with them, we recently profiled actual human precancerous nodules. There's different varieties of increasing evolution, which are abbreviated here as AIS, MIA, and IAC. But the point being is that when we do single-cell mRNA profiling, we are able to identify a subset of macrophages that produce these high levels of IL-1, and we find them to be accumulating within the lesions themselves and correlating with increasing stage of evolution. And this helped us draw parallels, essentially, between the preclinical work and clinical work that we had developed here at Mount Sinai, as well as, nicely seeing that similar observations were being seen halfway across the country. So an important trial is underway at MD Anderson where individuals with early stage disease have now been treated with canakinumab. So these are folks with very early stage lung cancer or patients with, based on chest CTs, defined precancerous nodules. And what was quite remarkable already is that if you compare the control group in terms of the volume of the tumor and the density of the tumor itself, you have a reduction in folks who, persisted their treatment with canakinumab. There were a few folks who had to stop their therapy, and in those patients, you don't see much of a difference. But for those who persisted on the therapy, you do see a nice reduction, and based on RECIST scoring, you do see a nice change from baseline. And so one of the things that we're working on now is trying to understand if we look at their blood, can we identify cellular or molecular biomarkers that then distinguish the really good responders from the not so good responders, even if everyone seemed to have benefited from the therapy one way or another. Okay, so the final take-home points I wanted to reiterate for you all was that it seems, with these developments, as we are studying precancerous stages of tumorigenesis, we are able to identify targets that would enable immunoprevention or immunointerception to reduce lung cancer mortality and morbidity. And it really depends on how we understand the balance between innate and adaptive immunity. Again, all of the things that I've been describing on the myeloid side is a reflection of the innate immune response. Macrophages and dendritic cells are effectors of the innate immune response. So understanding how they interact with their microenvironment and understanding their dynamics, what proteins they're expressing or cytokines that they're receiving, will be important for designing a targeted therapy for the immunoprevention of lung cancer. And all of this, again, seems to be dependent on the nuance that things may be stage specific, that things that we are looking at, in terms of IL-1 or IL-4 may not be as effective for patients with advanced disease, but that shouldn't be a reason for us to completely abandon it altogether. All right. And acknowledgements, I have to acknowledge for sure Miriam Murad, who has been my mentor for the past 5 years. I defended my dissertation last year, but I've been still sticking around. Tom Marin also, who has been more so my clinical advisor. All of the trials that he has allowed me to contribute to and work on has been a huge part of my career training, and many other folks in the immunology and immunotherapy department. Acknowledging also our collaborator from MD Anderson, Jay Zhang. And I mentioned Dr. Powell here from National Jewish Health Institute, the Mount Sinai Respiratory Institute. We actually are working with him right now to also leverage IL-4 using dupilumab to treat patients with COPD and seeing if we can reduce lung cancer incidence in those patients. And the rationale behind that is that dupilumab was recently FDA approved for patients with COPD. So if we can combine our knowledge of how IL-4 works in promoting the production of all of these immunosuppressive myeloid cells and how they promote tumor genesis, can we combine those two principles and see if we can reduce lung cancer risk in those patients? All right. Thank you.
Hi, thank you. That was fantastic. And the research you're doing is clearly going to make a huge impact in many patients' lives. I had a question about, you mentioned how you could now start adopting these therapies for patients who have risk factors for lung cancer, like COPD or people who smoke. And I was wondering if the same could be applied for people with maybe like genetic risk factors for lung cancer, or are exposed to certain environmental factors that can lead to lung cancer, and if that has been looked at, and if that same therapy could kind of be applied to those as well.
I think that's a really important question. We are looking at, for example, tumor mutations. So if you've got a family history of someone who has an EGFR mutation, a KRAS mutation, P53, so on and so forth, how that tracks with your predicted response to any of these kinds of interceptive measures. We don't have any definitive conclusion for me to share with you, but it is something that is on our radar. I think one of the other interesting concepts that we're pursuing but are struggling to really make progress on is this idea that if you can, because myeloid cells don't suddenly change just because the site of the tumor is different. So if you've got, for example, colorectal cancer, is this idea of IL-1 production by myeloid cells somehow different, or can we apply the same kind of IL-1 based intervention to prevent colorectal cancer, for example? Is something that we're also percolating on. Because also the bone marrow doesn't suddenly change in the same person, So the same way a bone marrow, the production of myeloid cells in the bone marrow would affect lung cancer, it should, that's the hypothesis, could affect, colorectal cancer. And of course, as many of you may be familiar with folks like Lynch syndrome, those folks are predisposed to developing colorectal cancer, among other things. And the idea that could be quite interesting is whether we can introduce some of these interceptive measures based on their genetic profile as well. Yeah.
I thank you for sorry, this is loud, such an amazing talk. I had two questions. One question relates to the, whether you have any speculations on the evolutionary purpose of this change in IL-1 signaling, why does that all of a sudden happen with age? And then the second, why does that anti-inflammatory phenotype, why is it beneficial? And then the second question relates to why that phenotype changes with age. Is there any speculation about whether it is related to other things that change with age? For example, like loss in muscle mass or insulin resistance or other changes that correlate with increased age, or whether you think it's really a primary aging thing?
To your first question, which I think is one of the most important conceptual questions for us to consider, is the fact that cancer, like many other, for example, chronic viral diseases, is, we think of it, typically as cancer is a disease of the tumor, or chronic viral diseases are a disease of the viral infection. But in fact, many of the negative sequelae that we see from something like even COVID is the fact that the chronic inflammation persists for so long and is so damaging to the normal tissue in our bodies that it then precipitates worse outcomes. So for something like IL-1, which is, wrapped up in the same kind of pro-inflammatory cytokine group as IL-6 or IL-8, TNF, all of these other things that we study for STEP, for example, prolonged production of these cytokines, first of all, as it relates to my project, fuels the production of more myeloid cells. But it does so because the primary evolutionary function of myeloid cells is to essentially promote repair, right? But then when you, then extend that concept of repair to the cancer setting, if you've got macrophages that are trying to repair the tissue by laying scars, fibrosis, so on and so forth, the only thing it's doing is essentially preventing T cells and K cells, all of these other things that need to get inside the tumor to kill tumor cells from actually getting in. So it's a bit of an extended answer to your first question, but nevertheless, it's a co-optation, so to speak, of the evolutionary primary functions of these cells. The second question, if I can remember it correctly, related to aging. So it's also a very interesting question, and it's one of the topics that we've been looking at. So long story short, the idea is that we think there's increased production of IL-1 because in the bone marrow where you've got hematopoietic stem cells, as they age, we found that their chromatin changes with time. And as their chromatin changes with time, we found that there is enough remodeling of the epigenetics that it increases the production of, it's getting a little bit in the weeds here, but it increases the production of things that we call endogenous retroelements, which are basically these ancient viruses that incorporated into our genome thousands of years ago. And when they are re-expressed, when they are reawakened, so to speak, it actually activates these molecules called cGAS and STING. These are, immune complexes within a cell that recognizes viral elements like viral RNA, viral DNA, so on and so forth. And because these endogenous retro elements evolutionarily are derived from viruses that incorporate into our genome, our cells recognize that. And when it recognizes it, it triggers a viral response, so to speak, an uncontrolled viral response. And part of that is the production of pro-inflammatory cytokines like IL-1, so on and so forth. So we actually tested, using reverse transcriptase inhibitors, which are the kinds of drugs like lamivudine, so on and so forth, that we use for HIV patients, Hep B patients, so on and so forth, to see if we can tone that down. And in fact, you can. And so we actually have a trial going on right now where we're giving reverse transcriptase inhibitors to patients with solid malignancies. And from the last I've heard, we're seeing some nice responses in many of these patients. So as far out as this mechanism seems to sound, the biology seems to be there. Yeah.
Thank you. You have one more? Hey, Matthew. Amazing work. Sorry if you already answered this question somewhere in your talk. You opened your talk by talking about checkpoint inhibitors and how using your antibody against IL-1 could be a way to get them to work in non-responders. Have you done any work on animals or in patients showing whether that could be a viable strategy?
So actually, I hid this slide because I didn't think I had time for it, but basically, if I can unhide, I don't know, can you see the data? Yeah, you can see the data. Basically, so because the standard of care is immune checkpoint blockade, PD-1 blockade, for example, are among preclinical scientists, the immediate reaction to seeing something work in mice is, does it combine well with PD-1 blockade? Because we know that clinicians won't even touch it if we don't show that it synergizes. And so one of the experiments I had done was to show that, for example, at least if you look at the histology, the combination of PD-1 blockade with anakinra seems to do a pretty good job of reducing the burden here. But I think, in terms of quantifying the cytotoxic CD8 T cells and NK cells that, elicit this response, what was quite interesting to see was that with PD-1 blockade alone, you do rescue the CD8 T cell response. You see a proliferation of these cytotoxic CD8 T cells, and that only goes up further in combination with anakinra. But what's interesting is that PD-1 blockade alone does not rescue the NK cell response, which makes sense. PD-1 is not meant to regulate NK cell function. But when you do combine it with anakinra, you do see that rescue. So we suspect that it's this combination of the rescue between NK cells and CD8 T cells that elicits the superior response in combination with anakinra. So in that sense, we have looked at PD-1, combining things with PD-1 blockade. In terms of whether it rescues non-response to PD-1 blockade, we haven't looked at that. There are models that are resistant to checkpoint inhibition, but that's not something that I've personally looked at yet.
Thank you all for staying to the very, very end, and most importantly, be very brief. I want everyone to just give our speakers a big round of applause for making the effort to come and speak about their really amazing work. And you can see that there is such a diversity and breadth of work that is done. I want us to take one other small applause for everybody who presented a poster today, because I also know that was an enormous amount of work, even if you didn't present early. That was huge. And then lastly, I know that there are some mentors in this room, and I want to personally thank every one of you for the amazing amount of time, effort, energy, heart that you have put into your students and helping them grow and learn and just blossom. So thank you to the mentors. And you can clap there if you want. And finally, as people have said already earlier, to the MSRO office, particularly Grace and Yakira, for all the work that they've done to put this together, to you all for your energy and your persistence in staying to the very end, to Dr. Thomas for his support of the medical school, and Dr. Charney. So thank you very much to everybody. I'm going to ask the 4 oral presenters to stay for just a minute, and everybody else have a great day.